All right, good morning. My name is Meagan Khau. I am the Director for the Data Analytics and Research Group within the CMS Office of Minority Health. I am joined by my colleagues today to speak about a number of data efforts happening at HHS in the last couple of years. One of the things that CMS released was our CMS Framework for Health Equity, where there are 5 priorities. The first one focusing on data collection, the focus of our topic for today. So I'm just going to choose to speak about priority 1. As a follow-up to that, we released a white paper advancing health equity, identifying a number of initiatives happening at CMS in terms of data collection effort to address disparities in the underserved communities. So for today, our sessions, you'll hear a variety of topics across the department in terms of the different effort we have undertaken to address and improve our data collection to better improve our data analysis. So first, we'll start with Nancy Giles Shaffer to speak about our data standards resource that we recently released that we're very happy to share with you all today. So Nancy.
Thank you, Meagan. Good morning, everyone. As Meagan noted, I am Nancy Chiles Shaffer. My pronouns are she, her. I am a Black woman wearing glasses with curly hair. I have on a Black blouse under a tan cardigan with Black pants. I also did not get the silver shoe memo, but I have on leopard print shoes. And I'm grateful to be here, as Meagan noted, to speak with you about our recently released data standards document. So the collection of disaggregated sociodemographic data is critical for health equity work, as was highlighted earlier in our discussions. And this is highlighted in particular from the administration, the Biden administration, firstly in Executive Order 13985, advancing racial equity and support for underserved communities through the federal government. There's a section in this executive order that highlights the importance of identifying methods to assess equity with respect to race, ethnicity, geography, gender identity, sexual orientation, and disability, among other factors. This executive order emphasizes the need to collect demographic data for assessment of health disparities and the impact of health equity initiatives. It also establishes a work group to gather necessary data, noting that many federal data sets are not disaggregated by race, ethnicity, gender, disability, and other key demographic variables, which impedes our efforts to measure health disparities. Thus, there is an emphasis on the need to gather this data for health equity work. Meagan also noted that the importance of the collection of health equity data is highlighted in CMS frameworks, in particular, the CMS Framework for Health Equity 2022 through 2032, which notes this in Priority 1, as well as the CMS Framework for Advancing Healthcare in Rural, Tribal, and Geographically Isolated Communities, highlighting the importance of collecting sociodemographic data in Priority 2. Given this importance, CMS OMH released in 2022 a data white paper describing the state of health equity data collection and consolidation across CMS programs. In this white paper, we identify gaps in the availability and completeness of sociodemographic data collection across our programs and noted that where the data is collected, many are done so at standards that are not current. Given this, the white paper notes that the lack of consistent data collection at a disaggregated level presents barriers to understanding the needs of specific subgroups, as well as to comparing data across programs and populations as needed or desired. From this, we saw that there was a need for an establishment of standards for sociodemographic data across CMS programs that we would align where possible in our collection. Additionally, we heard from external entities feedback as well as a request for guidance in terms of what standards to use when collecting this data. So from this, we developed a resource document, health equity-related data definitions, standards, and stratification practices in support of the framework and the need for alignment and collection across our programs. This resource thusly can be used for internal alignment, but also by external entities that wish to harmonize with CMS when collecting this data. From this, we will have the ability to have standardized data collection and stratification, allowing for comprehensive analyses that can be combined or compared across multiple programs or initiatives. The data standard resource document contains definitions, standards, and stratification practices for 9 data elements that are highlighted in Executive Order 13985, specifically race and ethnicity, gender identity, sex assigned at birth, sexual orientation, disability status, primary language, English language proficiency, and rurality or urbanicity of residence. For each of these data elements, there is a basic and a preferred standard, where the basic refers to the lowest level of data granularity, and where there is a preferred standard, this refers to a level of granularity or complexity beyond the basic standard. So starting with race and ethnicity, the basic and the preferred standard for this data element is the recently released 2024 OMB standard. This standard has 7 minimum categories, those being American Indian or Alaska Native, Asian, Black or African American, Hispanic or Latino, Middle Eastern or North African or MENA, which is the newest minimum category, Native Hawaiian or Pacific Islander, and white. For 6 of the 7 minimum categories, there are also detailed subcategories for the 6 largest populations within the minimum category. So using Asian as an example, the disaggregated categories provided are Chinese, Asian Indian, Filipino, Vietnamese, Korean, and Japanese. And then for each of the 7 minimum categories, there's also the opportunity to write in a response beyond the minimum or the detailed category. So again, using Asian as an example, the examples that are provided for the write-in are Pakistani, Hmong, and Afghan. The next data element are gender identity and sex assigned at birth, both of which have the basic and preferred standard aligned with recommendations from the National Academies of Science, Engineering, and Medicine. So for gender identity, the response options are woman, man, non-binary. If there's a possibility for a respondent to have already self-identified as American Indian or Alaska Native, then they will have the option to select Two-Spirit. I use a different term and prefer not to answer. Additionally, for sex assigned at birth, the response options are female, male, and I don't know. And it's important to use together gender identity and sex for aligning with United States Core Data for Interoperability, USCDI, for mapping. Next, we have sexual orientation, where the standard also is aligned with recommendations from NASM. These response options are lesbian or gay, straight that is not gay or lesbian, bisexual. Again, if a respondent has already self-identified as American Indian or Alaska Native, then Two-Spirit is an option. I use a different term and prefer not to answer. For disability, the basic and preferred standard is the 2011 HHS data standard. This standard has 6 questions assessing various abilities or some difficulties with a yes or no response option for each question. For English language proficiency and primary language, for each, the basic and preferred standard is also the 2011 HHS data standard. So for English language proficiency, the question asks, how well do you speak English? And the response options are very well, not well, and not at all. For primary language, the first question asks, do you speak a language other than English at home? If the answer is yes, then there's a second question asking, what is the language, with the options being Spanish and another language. For geography, specifically urbanicity and rurality, the basic standard is the core-based statistical area, CBSA, where the categories are metropolitan statistical area, micropolitan statistical area, and non-CBSAs. For analytic purposes, you can roll up these categories to urban and rural, where metropolitan statistical area would align with urban, and micropolitan statistical area and non-CBSAs would be rural. For the preferred standard, we have the rural urban commuting area codes, or RUCA codes, which have a 1 through 10 coding, with 1 through 3 representing metropolitan area cores, 4 through 6 micropolitan area cores, 7 through 9 small town cores, and 10 are rural areas. So again, if you wish to roll that up to urban and rural, codes 1 through 3 would be urban and 4 through 10 rural. There are several considerations to keep in mind with this resource document. First, it's intended as a technical resource to be used by organizations or entities that wish to harmonize with CMS when collecting, standardizing, or stratifying health equity-related data. Second, these standards were selected based upon broadest applicability and feasibility, considering the various collection methods and systems as well as usage of the data. Some of these standards are binding on CMS as a federal agency, for example, the OMB race and ethnicity data standards. However, others where they are not binding on CMS programs, we will move towards voluntary adoption where practicable and legally permissible for front-end collection. On the back end, CMS recommends harmonizing with USCDI to facilitate the sharing of interoperable data. And lastly, many CMS programs adopted standards prior to the development of this document. Therefore, where practicable and legally permissible, some collection will align with these standards over time. On this slide, we are showing the cover of this resource document as well as the link where it can be found. And then lastly, we encourage folks to reach out to us with any feedback or questions or additional guidance as needed. So we've provided here the CMS OMH mailbox, as well as our mailbox for our Health Equity Technical Assistance Program. With that, I thank you very much for your attention and look forward to questions at the end of the session. Thank you.
Thank you, Nancy. This resource has been in the work for quite a long time, so we're very happy to finally have it released to be shared with you all for the Health Equity Conference this year. And tying to that work, we also have taken another major initiative in a very short period of time to be able to collect sexual orientation and gender identity data on one of our administrative data form for one of the 3 M's. So I'm going to turn it over to Morgan Gruenewald to share with us on collecting sexual orientation, gender identity on the marketplace application.
Hi, good morning, everyone. Thank you so much, Megan and Nancy. My name is Morgan Gruenewald. I work in CMS's Center for Consumer Information and Insurance Oversight on issues related to the federally facilitated marketplace eligibility application. So as Megan alluded to, I'm very excited to be able to share a little bit of a use case of some of the sociodemographic data collection that Nancy talked about, specifically with regard to optional collection of sexual orientation and gender identity, or SOGI data, on the marketplace application. These new optional questions were added to the marketplace application for the first time last November for our last open enrollment period. And during this panel presentation, we'll plan to talk through CMS's process for developing these questions, the questions themselves, response rates from our first open enrollment period where we were asking these questions, impacts of this data collection on Medicaid and CHIP agencies, since we do have a single streamlined application kind of framework, and then next steps for this initiative. And just as some additional context, obviously Nancy provided a lot of really great information about the standards that OMH is putting forth, and these questions were developed prior to that document, as Nancy alluded to, is the case with a lot of CMS programs. So as Nancy said, there will be, ongoing efforts to align where we can, but we still wanted to talk through kind of our process for instituting this new data collection. Just as a little bit of additional background, our effort to include SOGI questions on the Marketplace application aligns with the CMS Strategic Plan's Health Equity Pillar, as well as HHS's SOGI Data Action Plan. We added these questions to the application in the context of several executive orders that direct federal agencies to leverage data collection to advance health equity for LGBTQI+ individuals and other underserved populations. And then in terms of other sociodemographic questions on the Marketplace application, we have always included an optional question about race and ethnicity. And SOGI was our first addition to the suite of sociodemographic questions since those race and ethnicity questions were developed in 2013. So we were really excited to be able to work on this. I'm going to briefly talk through the process that we went through when developing these questions. This process took around 2 years and involved a really broad range of stakeholders who we were very fortunate to be able to work with. As you can see, kind of at the start of the timeline, we started this process by engaging with experts from across CMS and other federal agencies to gather information about best practices, other similar efforts, as well as to share some of our tentative plans and to gather feedback from experts. In March of 2022, the National Academies of Science, Engineering, and Medicine published their report Measuring Sex, Gender Identity, and Sexual Orientation, which we'll refer to as the NASEM report. This was extremely valuable input to our work, and as Nancy mentioned, has continued to guide OMH's work as well. And the recommendations in that report greatly influenced the model that we wound up adopting for the Marketplace application. And then in late 2022, early 2023, the Office of Minority Health conducted extensive listening sessions with a broad array of internal and external stakeholders, really with the focus of understanding how SOGI data collection can help advance health equity. And we learned a lot from these sessions, but I think a big takeaway for us was just overwhelming support of adding these questions in places like the Marketplace application that made us feel really confident about moving forward with this effort. Another input that we considered when developing our questions, with which Nancy also alluded to, is the Office of the National Coordinator's Health IT Interoperability Standards. So we'll get into a little bit more detail about what adjustments we made to the NASEM model in order to ensure we were aligning with these interoperability standards. But just noting that that was another part of our development of these new questions. And then finally, once we reached the point where we had a kind of draft model, we conducted Marketplace-specific consumer testing that was facilitated by CMS's Office of Communications, and that informed some tweaks that we made to our model to better serve our specific consumers. And then, as I mentioned, in November 2023, in alignment with the start of our open enrollment period, we went live with these questions on the Marketplace application for the first time. So that was the how we did it. And now I'm going to talk a little bit more about what exactly we did. For some context, Prior to the addition of these new optional sociodemographic SOGI questions, there was only one question on the marketplace application about consumers' sex. This was a required question for applicants to answer. It is binary. The only two options are female and male. And I do want to highlight a limitation of this work for us is that there have not been changes to this question as it is collected today as of yet. We have some technical constraints that relate to our data sharing processes with state Medicaid and CHIP agencies that made it very difficult for us to change this current structure. So in our current world, we still ask consumers when they're applying for coverage to provide their sex, and they must select female or male. As part of this effort, we did add some additional, we call it help text or just context for consumers, indicating how we'll use this information when they provide it, specifically that it may be shared with their state Medicaid or CHIP agency, their health insurance issuer if they enroll through the marketplace, and potentially their provider. And that consumers who want to be asked about pregnancy as part of their application do need to select female here. So again, this is an existing limitation. This, is something that has existed in the marketplace for a while and that we still have today, and wanted to provide that context for you all. So that is what's staying the same. And now we're going to talk about what's new. So these are what we collectively refer to as the SOGI questions. These are 3 optional sociodemographic questions that are asked on the federal marketplace application. They're asked alongside existing race and ethnicity questions. First, we ask individuals to provide their sex assigned at birth. If they want to provide a sex that's not listed, they can select that option and enter free text. The second question asks for an individual's gender identity, and again, they have the option to enter free text if they choose. This is one area I'll highlight where we did depart from the NASEM model, which only includes a singular transgender answer option, whereas we've included transgender female and transgender male. And that was an adjustment that we made in order to ensure alignment with the Office of the National Coordinator, Health IT interoperability standards. So just want to call out some of the, kind of flexibility that we had to have as we moved through this process to make sure we were aligning with those standards. And then the third question asks about an individual's sexual orientation. Again, consumers have a free text response option. This is an area where we have some minor wording deviations from the NASEM model, and these were informed by marketplace-specific consumer testing. So just another example of somewhere where NASEM really was our North Star in a lot of ways, but we did also make changes to adapt it to our specific context. And again, all questions are optional. Consumers can skip them entirely if they choose. They can also select prefer not to answer, or they can indicate not sure if they do not know how to answer the question, particularly if they may be filling out the application on behalf of someone else. And we'll talk about that a little bit more too. I want to briefly touch on how we addressed consumers' privacy concerns. When consumers reach this question in the application, they are provided with links out to the marketplace privacy policy and an explanation on how the marketplace may use the information that consumers provide. And then we also have content trying to really clearly inform consumers that their responses or lack of responses in this area will not impact their plan options or pricing, their eligibility, the care that they are able to receive, or anything along those lines, because we know that's certainly a concern for consumers. Just a little bit more contextual information. In our application, we only ask these SOGI questions for consumers who are age 12 and older. And that was informed by some research that we did in collaboration with OMH. As previously mentioned, consumers' answers have no impact on eligibility, plan options, or plan costs, and also do not have any impact on the care that consumers can receive. CMS continues to expect issuers and providers to administer applicable and medically necessary care without regard to sex, sex assigned at birth, gender identity, or sexual orientation. I also wanted to add a little bit of additional context about the marketplace application more broadly that I think is important to keep in mind as we start looking at the data that we're collecting through this effort. One piece that I alluded to earlier is that because this is an administrative form, we often have application filers who are filling out the application on behalf of others in their household. So I think it's just important for us to keep in mind that these are not all going to be self-reported answer options. We may have some proxy reporting, and we try to mitigate this by, of course, giving consumers the option to skip questions or mark that they're not sure of the answer for a particular person in their household. But just an important piece of context to keep in mind. And then another key piece of context is that most individuals complete the marketplace application working with another professional, like an agent, broker, assister, or navigator. And we expect that impacts how consumers experience these questions, right? I think our perhaps picture in our head of a person sitting at their computer by themselves is not really accurate in most cases. And that's also something that we want to keep in mind as we continue to analyze the data that we're receiving. And then finally, before I hand things over to my colleague, I want to share what I'm calling a sneak peek of some of the data that we collected during the most recent open enrollment period. This is just focused on the response rates to the new questions, not the responses themselves. We're continuing to analyze that data. But this slide shows the response rates, so the proportion of consumers who selected an answer in response to the 3 new optional SOGI questions. As you can see, we had a response rate of 21% for sex assigned at birth, 20% for gender identity, and 19% for sexual orientation. So hovering right around that 20% mark for all of these questions. The slightly lower response rate for sexual orientation does align with some anecdotal feedback we've heard about consumers being unsure why this is being asked, perhaps hesitant to share. So that's something we'll continue to dig into. And then just for context, these response rates are a lot lower than what we saw during the same time period for the existing race and ethnicity questions, which hover more, closer to the 50% mark than that 20% mark we saw for the new SOGI questions. So analysis of what's driving these response rates and, more granular analysis of the responses themselves is ongoing, but we're thrilled to be able to share just a little bit of what's happening in our world with you today. And then I'm going to hand it over to my colleague, Karen, to talk a little bit about how this impacts state Medicaid and CHIP agencies, and we'll look forward to questions at the end. Thank you.
Good morning, everyone. I'm Karen Matsuoka, Senior Policy Advisor for Health Equity for Medicaid and CHIP. I'm an Asian American woman, shoulder-length dark hair. I'm wearing glasses, a dark gray blazer with white stripes. Really happy to be here. My pronouns are she, her. So picking up from where Morgan left off, she had mentioned earlier that the Affordable Care Act envisioned this more streamlined application process. And so invariably, anything that the marketplace does to the marketplace application will have huge impacts for what happens on the Medicaid and CHIP side. So what I'm going to be spending just a few minutes with you on is what exactly those main impacts were. And the first is not even necessarily about the addition of the 3 optional SOGI questions. The first goes back to something that Morgan had touched on, which is the help text. So as she mentioned, There's still a current required binary sex question on the marketplace application for technical reasons we were not able to address. And one of the things that we had heard, at least anecdotally, were that was problematic from an eligibility point of view, because pregnancy is one of the reasons or one of the ways that you can be eligible for Medicaid coverage, even if you're not eligible under the other criteria. And so we were very worried about the possibility that individuals, let's say, who are pregnant, but they identified as male, might tick a different checkbox, not knowing what the implications would be for their eligibility determination. So that text box that Meagan kind of touched on might seem like a very small thing, but when you think about how important Medicaid eligibility can be when it might be the only coverage you're eligible for, we thought the addition of that more explanatory text was critically important so that we can make more accurate eligibility determinations. And then second were the impacts of adding the 3 optional SOGI questions themselves. And here, the relevant thing to know is that because it is a single streamlined application process, state Medicaid and CHIP agencies have I'll put it nicely and say there are a lot of hoops that state Medicaid and CHIP agencies have to jump through if they want to deviate in terms of what they ask on their Medicaid and CHIP applications, if it's different from what's already being asked on the marketplace application. Also, for the most part, when states do want to deviate from what the marketplace has, really we're very much sticklers to allowing states to ask questions when they're required for an eligibility determination. And so prior to the marketplace having SOGI questions on the forms made it almost impossible for state Medicaid and CHIP agencies to directly ask these kinds of SOGI questions because, of course, we would never accept or deny coverage on the basis of how one identifies in terms of gender or their sexual orientation. So that put a lot of state Medicaid and CHIP agencies in a bind. And so when Marketplace decided to make this move 2 years, in the making to add these questions, it was huge for Medicaid and CHIP because, as you might imagine, we've had years and years of experience of state Medicaid and CHIP agencies wanting to do this, but just legally there wasn't a pathway. So because this is a big change in the Medicaid and CHIP world, we did issue what we call a Center Informational Bulletin, or a CIB, to explain to our state Medicaid and CHIP agency partners who then take this policy and then decide how they're going to implement it. We gave them more detailed guidance on what all of this means for them. And that CIB, there's a link here for anyone who, cares to dive into the details of it, after this conference. But really that CIB focused in on 4 main things. One, that the option to ask these SOGI questions on Medicaid and CHIP application forms is now an option, but it's not required. 2, for those states who do opt to move forward, it provided some instructions on what the process is in order to get CMCS approval for the addition, or if they even need approval at all. Third, and very importantly, the CIB covers what states' responsibilities are to keep this data confidential and what a reminder, basically, of what are the kinds of acceptable and prohibited uses for all sociodemographic data they collect, not just SOGI, but certainly including SOGI. And then fourth, we provided some sense of timeline with regard to when we're going to be expecting our state Medicaid and CHIP partners who do start to collect this data, when we're going to start expecting them to then submit that data to us as part of our existing kind of enrollment and claims data collection efforts, which we call internally a process called TMSIS. So as I mentioned, the link is here for anyone who wants to dig in deeper. There's also a resource slide towards the latter part of the deck that includes links to all kinds of things that our previous speakers talked about, including the CIB. Encourage you to take a look at that at your leisure. And then finally, just in terms of next steps, how we're all thinking about this, Morgan, Nancy, Meagan all refer to the fact that this was a hugely collaborative process. And so I think I speak for all of us when I say that it was a long process, but we're also very proud of what we've been able to accomplish. And yet we also know it's just the beginning. And so a couple of some of the most immediate next steps that we have in mind are, of course, to continue collecting this data, and as the data come in, analyze it, and not just analyze the data itself, but also continue to collect this kind of feedback, both from consumers themselves, our agents and brokers, our state Medicaid and CHIP partners, and start to really kind of assess what's working well and what might be improved, both in terms of how we ask the question, but also how we explain how we're going to use the information, all those kinds of things that you had heard alluded to earlier today. We will, of course, be, as part of that process, starting to identify best practices. So if we start to see that certain kinds of states have like higher response rates than others, we're going to want to start to dig in and see what is it? What is their secret sauce? And start to collect those best practices and then distribute them to our other partners to kind of spread the wealth and improve both response rates and data accuracy of our data over time. And then finally, we will continue to explore, as Morgan mentioned, how we can better align the way that we ask these questions to where CMS more broadly, as represented by Nancy's presentation, where they're headed, while retaining whatever necessary flexibility we might need as we learn from our consumers and stakeholders what's going to work well for the constituents that we serve. So with that, I'm going to hand it back over to Meagan for our next presentation. Thanks.
Thank you, Morgan, and thank you, Karen, for the updates and insight into that latest data collection. I want to echo that this was truly a team collaborative effort. If you ever hear that CMS works in silo, this project proves that totally wrong. We all had to get together to make this happen in the shortest period of time. So our next speaker, I will turn over to Abigail Viall from the CDC to provide us some insight in terms of their data modernizations. Abigail?
Thank you. And I'm really pleased to be here. So Abigail Viall, my pronouns are she and her. I am in a gray suit with a white shirt and black tennis shoes because I value comfort incredibly, and tennis shoes get you there. Also, I am the thing that doesn't quite fit on this panel. Everyone else is from CMS. I am from CDC. But getting to exactly what was just mentioned, this idea of teamwork, what we are exemplifying here and what I hope to also kind of walk through is how we are approaching protecting health as a team sport. So let's see if I can figure out how to do. No. Oh, green arrow, not the green exploding thing. Okay. All right. I'm continuing to. All right. Look, we have succeeded. So as I mentioned, protecting health is a team sport. This is something that our director, Dr. Mandy Cohen, has mentioned in a lot of her talks. And I think it's really important because it really gets to the heart of we're not going to accomplish our goals around health and health equity if we are not working together. And by working together, that means more than just public health, federal, state, and local, or public health and healthcare, but it also includes social services. It includes academia. Frankly, I was looking at this image before this talk, and one thing I didn't notice on here that should be here is that it includes communities. It includes patients and individuals and those with lived experiences. It includes everyone, and only by including everyone will we be successful. A successful team, though, needs data. Data is critical to success. If you watched Moneyball, I know I'm dating myself a little bit, but I really took a lot of inspiration from that. Data really made a difference. It really makes a difference in team sports. And it makes a difference here. We need data in order to inform our actions and to drive improvement. And that data needs to flow across the members of the team without a lot of effort. It needs to be accessible. And so one of the things that CDC is doing is we have released a public health data strategy. Our first version was in 2023. We released an update in April of this year. But our strategy is really about addressing gaps in data, making it easier to share data, and connecting data and data systems
between public health and other critical stakeholders, including healthcare, social services, and others. So, our team is a team informed by data, ideally data that we're sharing with our partners. And really, the public health data strategy that I mentioned is integral to our broader vision of advancing data for public health actions that equitably protect health, safety, and security. So the public health data strategy is our blueprint. It's our blueprint for achieving these aims. It is also our blueprint for accountability. One of the things that's really important about the public health data strategy is that we are setting milestones and we are publishing those milestones. We are saying, look, this is where we're going. And this is what we expect to hold ourselves accountable for. And we expect all of you, the members of our team, to hold us accountable as well. So that's a really important shift. And it really is a signal of how we are approaching things as a team sport. And, our execution matters, and we are executing. And this is a good news story. I'm not going to downplay the distance that we have to run, but it's important to celebrate the distance that we've come. And so just one example is syndromic surveillance data. Syndromic surveillance data is critically important, particularly in instances when we are dealing with public health emergencies, but also to detect things that are becoming problems, becoming emergencies, like identifying where we are seeing increases in opioid overdoses or other substance abuse disorders and substance use disorders. And so, I'm pleased to say that we have seen an expansion in coverage in this system so that now just under 80% of emergency departments, covering approximately 90% of ED visits, are contributing data to CDC systems. And why does this matter? Because it's allowing us real-time access to find where there are problems and then work with our team members to take action. Similarly, you'll see here electronic case reporting. Prior to the COVID pandemic, less than 200 facilities were reporting case data to CDC electronically. Less than 200. We are now at over 36,000 facilities sending automated data. And we still have a long way to go, but that's a real improvement. And this is an improvement that both increases the quality and timeliness of data for public health action while reducing burden for those who have to send the data. So these are good news stories, and those data are used to detect outbreaks, to direct community interventions, to direct patient outreach. So again, it's where we need to go, and we are getting there. But more remains to be done. And in particular, we need to think about how to better detect disparities in data and how to better detect disparities using the data available to us and then use that information to direct action. So we need to understand what is happening and to whom, where are there disparities, and what's driving those. Can we dig under the surface so that we can understand what do we need to do in response? Because again, it's never data just for data's sake. It's data to do something, to help people to take action. And to that point, again, we are prioritizing actionable data. Thinking about what are the end goals? What would we do with this information? And then what's that information need to look like? Where do we need to get it? So thinking about what's the intervention? Where might we direct interventions? And then taking that as our starting point to think about what we would ask for, when, and from whom. So let's walk through a couple examples of what this would look like and why it matters. So earlier, I think, Meagan, you showed the 2024 new OMB standards and the fact that there were 7 major race ethnicity categories, and then there were some subcategories. This is an example of where those subcategories matter and thoughtful disaggregation makes a difference. So what we saw early in the COVID PHE is that in Hawaii, there's a tendency to kind of put Native Hawaiian and Pacific Islanders together and look at that as a group. And that, that makes a lot of sense in a lot of different contexts. But people were starting to say something isn't, there's differences under the surface. And so when the Department of Health in Hawaii dug into it and started looking at what's happening under that category, breaking it out by those subcategories, they saw real disparities within that group of Native Hawaiian and Pacific Islanders. And using that data allowed them to then engage community groups and say, how do we reach some of the populations that are most affected, the Marshallese population? What do we do? How do we look at our vaccination campaigns and think about the messaging, think about the outreach so that it is community driven and culturally appropriate? And so this is a good example of where thinking about our data standards and when we need to dig down another layer is incredibly important and powerful in terms of public health implications. Another good example, and this is an example focused more on diversifying data sources, are maternal mortality review committees. For those not familiar with this term, MMRCs are multidisciplinary committees that convene at state or local levels to comprehensively review maternal deaths that occur during or within 1 year of the end of pregnancy. Their work really helps us understand not just where disparities are happening in maternal mortality, but underlying drivers. And that combination of what's happening to whom and why is useful to guide interventions at patient, provider, facility, system, and community levels. And as you can see, the value proposition is being realized by a lot of our state partners, and the number of MMRCs have grown over the last decade. CDC continues to support that growth, and through awards to 44 states and 2 U.S. territories. Okie dokie. Oh, gone too far. And this is a good example of where the data from MMRCs can help us examine not just where there are disparities, but again, those drivers as well. And because MMRCs are multidisciplinary, they both embody the idea of health, protecting health as a team sport, and enable that. For example, using the data from MMRCs, combining it with that from Medicaid agencies, it could allow Medicaid programs and managed care organizations to better understand when they're seeing disparities like this, when they're seeing racial and ethnic disparities, what's driving it. I mean, it's one thing to detect a disparity. It's another to say, what's under the hood here so I can do something that actually makes a difference and helps people. And that's the kind of thing that combining the overarching information on where there are disparities with the depth of information that MMRCs can surface allows people to, again, say, what are the drivers? What should I do with this information? And again, because those are multidisciplinary from the start, they already provide a sort of forum and group that's actuated to work together with various stakeholders and bring change. So again, it's just a good example of when we start to diversify and bring data sets together that we can take more collaborative action. Oh, sorry. So finally, how is CDC moving forward? We are taking a number of steps in this space, and I just want to highlight a couple. One is better integrating and increasing the inclusiveness of existing systems and data sources. I mentioned our public health data strategy. One of the new milestones added to that refresh was about increasing reporting of social determinants of health. So really starting to say, as part of how CDC is operating, we're going to hold ourselves responsible for increasing the flow of these data because they are critical to public health action. And again, we are going to put that in our strategy and post it for all to see and hold us responsible for meeting that milestone. Second, inclusive data standards and validated tools. I think there was mention previously to USCDI. For those who are not sort of written in on what does that acronym stand for, the USCDI is the United States Core Data for Interoperability. It is a national standard that sets sort of a floor of what data elements should be available for electronic communication. We continue to work closely with partners at ONC, with our partners at CMS and elsewhere to say, what should be in that national baseline? How do we grow it over time? And how do we make sure that elements that are critical to detecting and responding to health inequities are in that baseline, and that there are standards and they are being used by our partners? So that's one of the ways that we are addressing inclusive data. And then finally, tools to address identified gaps. One of the ways that we are taking a step here is to give frontline staff the tools and support they need to detect and respond to health disparities. Because frankly, and this is not surprising, but it's a lesson that we always relearn. Asking questions about substance use, about disability, about housing status, that's hard. That's not always easy. And what we found during COVID is we were getting case data that often lacked these variables. And when we talked to the case investigators, they kind of said, we don't feel comfortable asking that. Now, there were a ton of other more structural reasons that those data were not being collected too, and we need to address those. But in terms of empowering frontline folks to feel comfortable asking for that information and to do it in a way that is sensitive, that we can do something about. And so I'm pleased to announce that we have worked with CSTE, the Council for State and Territorial Epidemiologists, to roll out a new training engaging with sensitivity to improve data collection during case investigations that will be released in June, so later this month. And it's freely available to anyone on the CSTE Learn platform. You don't need to be a CSTE member to access it. So again, just a couple of the ways that we are working together, and we'll be working with our partners at CMS and other federal, state, and local agencies to protect health as a team. Thanks.
Thank you, Abigail. We'll now open it up to questions. We have folks with microphones walking around. Each of our speaker has a microphone as well. Any questions? Yes.
Hi, Johnson from LMI. Thank you so much for this session. I think nothing will get improved without data. So it was just reported 14% of the Z code is leveraged in this country, and been talking to clinicians that they are burned out to go through the electronic healthcare record down to the Z code, and they're not incentivized to use that Z code for social determinants of health. I would love to hear about your strategy improving and having clinicians incentivized to use that data. Thank you.
So, not quite the topic of our presenters. However, we have received these questions numerous times. Unfortunately, we don't have the incentive solution at the moment. There have been a number of initiatives the CMS has been working on regarding Z codes, specifically on the housing instability recently, but we are looking into what we can do to better improve it. The one thing I will put a plug in is that we are looking at the Z codes reporting. It is very, very minimal at the moment. So to the extent where we can improve that reporting, it will provide us better data to make better determinations for program and policy changes.
Hello, good morning. My name's Petula Brown. I'm from Michigan. Very informative. My question, I'm not sure it was in the purview of this session, but a lot of your talk was focused on data collection, but collection's only the beginning. It's how the data is used. And my interest is how the data that's collected is being used, whether via analytics, machine learning, AI, and in particular, last fall, I had read in the trade press about how some health plans were using data to make, and using algorithms to make coverage decisions. And I'm just curious whom in CMS or HSS or CDC or any other organization is looking at, once it's collected, how the data is used. Because I think particularly in many industries, not just in healthcare, data is very valuable and used for a variety of things to make a lot of decisions. And I'm not sure if the use of your data is overseen by some group or if you have any position on that type of use.
Thank you. Abigail, you want to start and then we'll go this way?
Sure. I think that is actually an excellent question. And it gets back to that idea of it's not just data for data's sake, it's data for action. And in fact, often it's important to start not with saying, what do I need, but what will I do with it? And then we walk back to what do we need? And then what's the most efficient way to do that? So, for CDC, that is actually how we have started to really think about this as a standard is what do we need? What's our use case? then we think back to okay, how does that mean? What does that mean in terms of what we are collecting, the frequency that we're collecting it from whom, and I think a good example of that is that data from, or that example from Hawaii, where it's, in that case, it was, okay, with this information, we can do something. We can engage community partners. We can engage the right community partners, and we can use that information to think about, where are we falling short in our vaccination campaigns? Where are we falling short in our outreach? And then target or titrate, improve, and move forward together. And that is exactly how we need to think about it, not just for CDC, but when we are talking about as partners, what are we collecting? Why? How do we reduce the burden? And how do we tie it to action?
Here. Sorry. So I might. Good.
Yeah. All right. That was loud.
So very similar to what Abby mentioned, CMCS is using the data in much the same way. I don't know how much folks are here in the weeds on, how long CMCS, Medicaid, and CHIP have been in the business of doing this kind of data collection and quality measurement. It's not been very long. It's a little bit embarrassing to say, but we didn't do quality measurement at all until 2009 with the CHIPper legislation for children. We had the Child Core set of quality measures and outcome measures. And then in 2010, the Affordable Care Act came around and said, you got to do the same thing for adults. We're no longer just a health insurance company. We are a health care organization. And if we're going to do that job well, we kind of have to know, what are the main conditions? What are the prevalence? Are individuals having a tougher time, some getting access to coverage than others? How about access to care? When they get the care, what are their outcomes? What kind of quality of care do they get? So all of these things are things that we in CMCS have only been doing for roughly the past 10 years. That said, the way that we use the information, to Abby's point, is not just to collect the data for the sake of data, but to hold ourselves and our state partners accountable for what those numbers tell us. And very similar to the experience that Abby mentioned, once we started to then stratify those individual quality measures by factors like race, ethnicity, urban, rural, disability status, we started to see that this one data point that we might have had for hypertension under control looks very different depending on what community or what population or what demographic you're talking about. And just to give you a sneak preview, tomorrow, I will also be on a panel talking about tribal health. I'll be on a panel talking about maternal health. You'll actually see the very first instances of what this data look like for some of our key priority populations and areas of focus. And you'll see why looking at just the data point for all of Medicaid or a particular state, while that's very important and is 10 years in the making, is clearly not enough if that single data point then hides all kinds of variations. Once we now have the information, of course, that then allows us to do the important things that Abby mentioned, which is prioritize our areas of focus. So we know in maternal health, we're not doing a good job if we're not looking critically at the African American population as well as the Native American and Alaska Native population. It turns out, and again, sneak peek to tomorrow, that when it comes to something like severe maternal morbidity, depending on what race you are, it turns out that the leading causes of severe maternal morbidity are different. That's really important information for us to then pass on to our clinical providers to be able to do something different, because clearly if sepsis is the issue for one population, that's going to look different, the intervention, than if something else, hemorrhaging is the cause. So absolutely, I think 100%, this whole exercise has never been about data for the sake of data. It's what are we going to do about it? I think we're very early stages in being able to do what we'd really like to do with it, just because, as in the SOGI example, we've only had 1 year of this. But as the data increase, I think you will definitely see more strategic use of this data as well as sharing. And while I have the platform, I just wanted to also mention, in response to the earlier question about social demographic data, or social determinants of health. So absolutely, what you say about Z codes is true. Our clinicians are very under-resourced, both in terms of time and reimbursement. And so one of the things that we're trying to also do more strategically is to recognize that a lot of this information is already being collected It doesn't necessarily have to be by a provider. It doesn't even necessarily have to be by the Medicaid and CHIP agency. And a great example of this, we've been working very closely together with CDC, is they've had for now decades BRFIS, the Behavioral Risk Factor Surveillance System, which for decades has collected data that can be stratified by state, by payer, by race, ethnicity, by disability, by SOGI. And for the past 2 years, and I think for 2024 as well, they're going to be fielding a social determinants of health module. So, even as we're building the data infrastructure that we would all want, that Abby has started to mention, it's important for us to remind our partners that a lot of this data is already there. We just have to be really creative about identifying it and finding ways to tap into it, and helping our state Medicaid agencies, in my case, figure out how to then pay for it. And all of these things are possible. It's really just a matter of kind of thinking strategically about how we can achieve the maximum benefit for, within the resource constraints that unfortunately are very real. And are the parameters within which we all have to kind of work.
Post your time started. I want to get Morgan and Nancy.
Sure. Yeah. I'll just briefly add from the marketplace SOGI perspective specifically. As Karen mentioned, this is a very new data collection effort, but I think we hope to be able to use this data, perhaps unsurprisingly, to help identify disparities. We've been able to use other sociodemographic data that we collect in the past to help, drive policy changes around how we verify consumers' income, for example, to try to reduce disparities in consumers who are losing access to coverage as a result of how some of those policies were working. And the more data we have, the better we're able to identify those disparities and put forward policy proposals to try to mitigate them. And then I think we're also looking forward to analyzing some of the free text responses that we receive as part of this. One of our goals, in addition to being able to identify disparities, is also making sure that consumers filling out the application feel that they're able to respond in a way that reflects their identity, in which they feel dignified, et cetera. So we're looking forward to using the data that we collect to help us inform any future changes to our model, because as we've mentioned, this is going to be an iterative process and we have a lot to learn.
Hello. Okay. For CMS OMH, I will also highlight that on our website, we have a research and data tab where you can find several examples of how we use sociodemographic data for assessment across CMS programs, most frequently in Medicare and also in Medicaid. So you can see stratification reports, stratified reports that look at stratification, for example, by flu vaccination rates as an example across various sociodemographic groups. We also release regular data snapshots to show disparities that may exist for different chronic conditions, and also different fact sheets, such as recently one focused on mental health and other disparities that are present in LGBTQI plus populations. So there are several examples there of how we regularly use the data to assess disparities, which can then be used by the programs to inform policy.
All right. Well, thank you, everyone. And thank you to our speakers again for very informative sessions. We'll be around if you have any additional questions. So thank you very much.